Deirdre, it is an absolute pleasure to have you in the podcast studio. I did feel I was meeting a superstar now today. You are famous in Ireland for your menopause advice and information, and now your clinic in Holles Street. Can you just give us a little bit of background as to why and how you got into all things menopause?
By accident, I think, like most of my life. I obviously traveled from America. You can hear from my accent, because I really wanted to do medicine as a younger person, but I didn't want to incur the kind of huge debt that went with it. And then I fell in love with this country. I'm Irish genetically. My 4 grandparents are all Irish born. So we'd been here a lot as kids. I was very familiar with the rural parts of Ireland. So I said, okay, I'm going to go to Dublin. I'm going to do medicine. But I never had any interest in anything to do with women's health whatsoever. But when I started having kids, I was really torn. I did not want to be one of these moms who relied so much on a childminder or a creche. I really wanted to be with them. And back in those days, women in medicine had very few options. And one of the only things you could do like part-time was women's health. So I said, fine, I don't know what that is, but I'll just do that. And that's why I ended up doing this line of work. I had no real ambition for it whatsoever. And I love it because, you know, it doesn't take a huge amount of research and reading to become quite competent. And the amount of positivity you can bring, the kind of benefits you can give to women who are struggling with a tiny little bit of advice, it's just miraculous sometimes.
Yeah.
Menopause was always a part of women's health. Like mostly I was doing things like heavy periods, pain, endometriosis, that kind of stuff, contraception, more reproductive stuff. But then when older women would come in, very few people seemed to be as aware of why they were feeling rotten in midlife as we are now. But a lot of times they would come in with classic things like flushes and sweats and sleep disruption. And back when I started working in the family planning clinic, I was with the Irish Family Planning Association for over 16 years. We used to give them all Premarin, the horse's urine tablets, if they wanted it. And amazing results. So I was like, okay, menopause, no problem, piece of cake. But then in 2002, the whole Women's Health Initiative flacca started, where people became terrified of HRT. And that's when I really started to notice the struggle, because now people who were very afflicted and whose lives were really badly impacted by their menopause symptoms were too afraid to use the products that were available to them, because they were convinced, as were a lot of healthcare people, that HRT gives you breast cancer, which it most certainly does not.
Did you stop prescribing it back then as well?
None of us did. None of the knowledgeable.
Okay.
I don't know if that's the fair word. None of us working in the industry who know how to read a scientific paper were that affected by the WHI publication, because even their data, which was very hand-selected, very elderly women, many of whom were obese, which is a big risk factor for breast cancer, were being given copious amounts of horse's urine estrogen cocktail. So there's 14 different molecules of estrogen in Premarin. Like, it's not one estrogen. And even that data said the relative risk increase was 1.27, which is a relatively small, much about the same as alcohol, and about in a fraction of what overweight and obesity confer. So when we looked at that data ourselves, and obviously we had the British Menopause Society even back there to guide us, we said, interesting study, not practice changing. Do not do anything different on Monday morning based on this study. Mm-hmm. The editorial was extraordinarily opinionated and blown out of shape. They wrote, marked increase in breast cancer detection amongst women using the estrogen plus the progestogen, and a protective effect from the women on the estrogen alone. And we were like, that's ridiculous. Yeah. That doesn't even make any sense.
No.
There are estrogen receptors on breast cancer. How could women on estrogen only HRT, horses HRT, have a reduction? And they did in that study. So that study didn't hold a whole bunch of weight for us in the industry, but it destroyed women's lives, because most prescribers and most of the general public believed the editorial, and then all the media come out with HRT will give you breast cancer. It's poison. Don't touch it.
And because I came out of pharmacy in 2003 and I saw an absolute fall off the cliff with HRT prescribing.
You couldn't give it away. Couldn't give it away. Yeah. And like these are people who are like so unwell, so affected by symptoms, like suicidal with now it's a very unusual, a small group of women who are that badly affected by menopause, but they're there. And they absolutely require management, and they weren't accepting it. They weren't even coming in for help because they believed that the only thing we could offer them would be something that would give them breast cancer. So it was quite a dark time. Now, I did have a fairly strong cohort of women said, I don't care. I can't go back to where I was before you put me on that stuff, So, and we didn't just have Premarin. We had like a lot of oral. We didn't have any patches or gels back then. I think we might have had one. We might have had Divigel, but we didn't have the breadth of body identical, ovarian similar hormones that we do today. So our prescribing options were quite limited. But even our Premarin ladies and Prempac-C ladies were like, I don't care. You got to die from something. I can't live the way I used to live before. And we were like, God bless you, But that's not the choice you're making. You're not choosing cancer. It's the relative risk is very, very small. And that pictogram, that pictogram of the 1,000 ladies between 50 and 60, how many get breast cancer, how many of them get breast cancer after so many years on HRT. Though that picture came out in 2003, and it was amazing. It was such a great tool for showing people what actual risk that study demonstrated, and that it wasn't catastrophic the way the media were portraying it, But those were lost years. I would say for the next 10 to 12 years, it was a really dark time for menopausal women because the general attitude towards HRT was bad, don't take it, I don't do it. I can, with no shame, a lot of prescribers say, well, I don't do that. I'm like, okay. But it's still I don't think you're allowed to do that. It's like saying, I don't do blood pressure medicine.
I know.
Who gives you the right to say what you do and don't do? Like, this is guideline.
Yeah.
There's guidelines around this for general practice.
But it's happening now in general practice still, Deirdre, and that's
for different reasons, though. Because as you well know, general practice is on its knees. The demand for patients' appointments is overwhelming, and the number of practitioners in the country is going down, down, down. People are retiring. People are burned out. They're getting out as quickly as they can. And a lot of the younger doctors are moving. So good luck getting a GP's time. And when it comes to something that's a little bit more nuanced, time demanding, like a first menopause chat, I can understand why people, but I don't think it's ethical to say, I don't do it. You could say, listen, that's a very time-consuming conversation. Like a lot of my friends and colleagues will say, we do discuss menopause. We don't do it in a 12-minute, €50 appointment.
Yeah.
We can't give it the time it deserves.
Yes.
You deserve. So some of them will say, here's some reading that you need to do beforehand. We'll get maybe the general practice nurse to have a conversation with you about lifestyle red flags that you may have that could affect menopause, and that if you are interested in looking at some kind of a prescribable therapy for your symptoms, including HRT, but there could be other ones as well, then by all means we'll bring you back, but it'll be a longer consultation. So for private patients, it'll be
more expensive.
And I think that's completely justifiable because it is a long chat.
Yeah, no, and I've had those conversations with people where they feel that, I suppose, if they are going to see a menopause specialist, the price of the consultation is too much. But it is explaining that to them, that it's a longer consultation. This is the doctor's time, and there's all that goes with it. But unfortunately, it's for people that don't have that extra money to spend, where do they go?
I know. And that is problematic. I'm a huge fan, having graduated from the College of Family Planning Well Woman, I'm a huge fan of family planning and well woman clinics. And certainly there isn't one of them in the country that doesn't have a lot of staff, not maybe every member of staff, but a proportion of the staff would have really good menopause skills. So I don't know how they price themselves that way. I don't know. They're generally much more affordable, in Dublin anyway, than some of the more swanky private practices might be. And I'm very cheeky. I always say, I want you to ring the family planning clinic, ask to make an appointment with any of the staff over 40,
Oh, yeah.
Because, a little empathy goes a long way.
Yes.
Yeah.
I agree.
And tell them you want to talk about menopause. If you're not suitable for our service, but you really need help, but you're in a place where your GP is just not in a position to give you menopause advice,
What about the women that are being told, you're 48 and you're too young for menopause, even though they have several symptoms, because it is happening?
Yeah, they're being misinformed. And that's just ignorance on the part of the nurse or the doctor who said that. So as you well know, the word menopause is really misleading. It's a gynecological term that demarks the last day of the last menstrual period a person with ovaries will ever have. And it's not helpful, the word menopause, because that's not what we're talking about, okay? Long before the final day of your final menstrual period, the other function of your ovary, besides making eggs, which is to make all your hormones and stuff, starts to falter. And throughout the 5, maybe even 8 or 10 years before your final menstrual period, you will have episodes during which your ovarian hormonal symphony gets out of control.
I love that word, symphony, because that's what it is, isn't it?
There's so many hormones, and they all work together, and they're controlled by hormones in other parts of the body, and the whole thing can get noisy real quick. You just need one bad cello in there to screw it up for everybody. You know? So, and that's perimenopause.
And we never even used that term up until like a few years ago. Well, certainly not colloquially, or the general public didn't know.
We didn't recognize it, a lot of times in younger women, particularly, some of the symptoms of perimenopause and PMS, PMDD overlap. So I think there was a recognition of, where is this? Why is she unwell? Where is it coming from? Because so many of those symptoms in younger women and women in their sort of 45 to 50 age group are mood related. There was a tendency to just identify this as primarily a mood disorder and put everybody on mood drugs, which up to a point actually helps a bit, but that's not the appropriate way to have that conversation, So there's a lot of, it is a hard, perimenopause is a hard, consultation to feel confident in. It's not that the GPs and nurses can't do it. Of course they can, but there's so many moving parts. It can be confusing sometimes,
Yeah. So why do people come to you, and who comes to you, actually? That's the question.
Well, what happened was, a couple of years back, the National Women and Infants program, the HSC's program for that group, listened to a group of people convened as the Women's Health Task Force. And they said, where are the most Black areas when it comes to women's health in Ireland? And they highlighted endometriosis and fertility. And as you know, that there's some movement in those areas at the moment. But one of the other big areas, they said, was menopause, that there seems to be huge ignorance in primary care and hospital medicine around menopause and its impact on people. Moreover, if you don't have the resources, you can't go to a free private service, So the government gave so many millions to set up 6 regional menopause services around the country, and ours in Hollis Street in the National Maternity Hospital was the first. So in November 2021, myself and my beautiful nurse manager got together, and we just started opening the floodgates, basically. And because we were the first and the only ones at the time, the demand was massive. Mm-hmm. So the two of us quickly realized that we can't see everybody who ever had a hot flush in the 26 counties, because we wouldn't see anybody. Like, our waiting list would be 5 years if we let that carry on. So we decided among ourselves that we would give advice when doctors were referring in patients with typical, normal, standard menopause. But we would only give appointments to people who had comorbidities, other medical conditions that made it very difficult to have conversations around things like HRT and stuff. So the British Menopause Society have identified about 8 or 12 different, not just cancer, but things to do with ischemic heart disease and cardiovascular disease, stroke, that kind of stuff, as special areas, special considerations. So if a person, say, who's got heart disease now is menopausal, they ideally should have their menopause conversation with an expert. So that's what we do. We accept referrals from our catchment area, which is most of Leinster, from GPs for women who are getting menopause difficulties, but who also have a background of things like hormone-sensitive cancers. 80% of our referrals are ladies who've had breast cancer.
Okay.
A big proportion are people who've had blood clots, particularly blood clots that happened while, say, pregnant or on the pill. And then all the other stuff. There's a lot of other stuff in there, like ischemic heart disease, stroke, some of the weird immunological conditions, HIV/AIDS. It's funny enough, we don't get a lot of referrals. I hope to God they're well managed by their own infectious disease groups, but we definitely will accept those ladies,
Okay. What's your wait list like then? Because that's a huge, like the whole of Leinster, that's massive.
Unfortunately, it's come up to 6 months, but I'm happy enough with that insofar as compared to other hospital-based services, as you can well know, it's like, that's not too bad, Like try to get a dermatology appointment in this country, And then more interestingly, when we travel and email back and forth with our colleagues in the UK, most of the NHS clinics over there, you're looking at 2 years. Now, that's ridiculous. Nobody can be identified as having moderate to severe menopause problems that warrant referral and then be told you could now sit in this bathtub for 2 years and wait for your appointment. That's absolutely ridiculous. So what I like to hope is happening, and certainly what we do, is we would often write back to the referring doctor saying, of course, we'll happily take her. In the meantime, here's some information about what you guys can work on together.
Yeah.
And it's not uncommon that when a woman does finally turn up, she's fine. That she and the GP. Now, I would have loved for her to cancel that appointment. But they never do.
Okay. They just want to see you, Deirdre.
That's what they say. They're like, I just wanted to meet you. I'm like, oh, I'm so thrilled. But I'm thinking, like, all those other people we could have. Anyway, it's fine. I'm delighted. I'm honored. But like, yeah.
And what happens when someone does go through your service and you get them on the straight and narrow, so to speak, or you sort them out?
Our goal is to discharge.
Okay.
Like we cannot hold on to people. I mean, there are some people who we don't book review appointments with, but we don't close out their file. And those would be, we have a handful of ladies who have had a significant breast cancer diagnosis, who have considered and or explored all the alternative options, but whose symptoms are so marked that their quality of life is destroyed by their situation, and they have opted to go on HRT.
Okay.
So we would never discharge somebody with a breast cancer in their past who we've prescribed HRT for. Okay. We want to keep them close.
Yeah.
But everyone else we're trying to get rid of. Because once you're well, what is the point in just gassing with me every 6 months? The goal is to send you back to your referring doctor so that I can open up another case for a new patient.
And then that their original doctor as well knows what you did, can see it, and then can they?
Of course, and so
can they learn from you and then go and prescribe?
They do,
So they can. It's not just you that can prescribe HRT to breast cancer people.
The guidelines from the British Menopause and the International Menopause and EMAS and all the groups is that initiation of HRT for women in certain circumstances should ideally be done by somebody with specialist recognized specialist training, like us and me and Nicola and all the other people who work in the specialty services. But it's not exclusive. Like, say you're living outside a catchment, or say there is just nobody to turn to. If you have a really engaged GP, they would often write in or maybe put a message up on our little private WhatsApp group that we have, our Telegram group, and say, listen, I cannot get this lady into a specialist, but this is her story. What does anybody say? And like, we would often just give guidance through email and text,
Okay.
Yeah. So it's not mandatory that someone with breast cancer, we typically use non-HRT therapies anyway. So why not go through some of them with your GP while you're waiting for your specialty referral? And you may hit on something you love, and then you don't need to talk to a specialist,
Can you talk about those non-hormonal treatments that women who have had breast cancer have? Like, I've had so many messages from women saying triple negative breast cancer, they've been catapulted into menopause, they are young women, their lives are destroyed, and they are told there's nothing for them.
Yeah. So it depends. A lot of it depends on the symptoms. So with people who are going through typical menopause, just natural menopause, I'm getting older, my ovaries are kind of getting tired, my hormone symphony is getting a little on the noisy side. Generally, when you balance and stabilize hormone fluctuation, you get rid of most of the symptoms. Certainly 70 to 80% of the symptoms recover, and that's across the board. we don't do that with people with breast cancer. We don't, because we're not using HRT as a rule. We are basically taking a list of the top 3, 4, 5 most troublesome symptoms and trying to make an impact on each of them individually. So it's a little bit more tricky. So like say somebody comes in and says, a lot of people with triple negative will have genetic cancer. So say someone with BRCA1, often your high risk is for triple negative breast cancer. Okay. So some of those BRCA ladies will have had their ovaries removed because they also are high risk for ovarian cancer. But because their risk for breast cancer is still high, and if they haven't had a prophylactic mastectomy, they'd be very loath to put them back on estrogen, although I think they should do and ought to do eventually when, depending on how long, it depends. Like if you still have your breasts, it is kind of tricky. You're concerned about starting those people on HRT, but you can. So
someone who's had a mastectomy in that case with BRCA and had their ovaries removed, they can go on HRT?
Straight on it.
Yeah.
Particularly if they're under 40 at the time of their surgery. So they tend to try to drag out the surgery until you're a little bit older. The goal there being not to increase your risk of osteoporosis and cardiovascular disease and all the other stuff that comes with early catastrophic hormone loss. But even older women will sometimes, after oophorectomy, mastectomy, will be so afflicted by their menopause that we'll put them on HRT. And the recommendation there is maintain them on HRT, estrogen replacement, until they're at least the age of natural menopause, which would be 50, 51. At that point, we don't know whether it's good or bad to continue the estrogen. There's no data, as there isn't for so much of what we do. We leave it up to the women to make their own decision at that point, yeah.
Is it difficult to get that hormone balance right once their ovaries have been removed?
Not necessarily. Everyone's an individual, obviously. I find that the younger you are when you've gone through ovarian hormone loss, surgical hormone loss, not spontaneous, the greater the demand for estrogen replacement. So sometimes you're using quite copious amounts of HRT, way more than you'd ever use in a typical 45 to 55-year-old lady, which can be kind of scary in itself and also can bring on side effects because estrogen isn't without side effects. So they can be a little bit more, you do want expert advice in that situation. Yeah. When you're getting into the 125s, the 150, the 175 units of estrogen, the top of your head could blow off with a bit of a migraine if you're not careful. So you do want somebody who knows how to play with delivery systems and balance it with the progestogen for people who still have wombs. But when it comes to things like menopause-related mood disorder, there are so many things that can help. So across the board, we recognize we would appreciate people to consider cognitive behavioral therapy. Now, I know there was a big backlash in the UK
my goodness.
recently.
It was like mental. People are saying, take this instead of hormones, and they're doing we're going backwards instead of forwards. But I think I think they pushed out incorrectly.
They misinterpreted that, and I think they did it on purpose. I think some of the kind of mouthier menopause advocates were using that as a springboard and causing distress where it didn't need to be.
Because CBT has always been recommended.
CBT is amazing. And you get almost in clinical trials, you get almost as good mood improvement and flush relief from CBT as you do from HRT. Now, not for everybody. Obviously, nothing is for everybody. So to not consider it would do women a disservice. But what the NHS never said was that it would, what NICE never said was we're looking to replace HRT prescriptions with cognitive behavioral therapy. They never said that, but that's how they got taken up. And then there was this big backlash,
How did the media get away with that though? Just being allowed, but it's like the Women's Health Initiative. They literally ruined the lives of so many women by putting out the incorrect information. Sorry, I feel like a bit of a rant coming on. How is it allowed to happen?
Well, people who work in media, any news is good. Any notoriety is helpful to get recognition.
And paper sold and all the rest.
Exactly. So if you want clicks on the phone, if you want papers sold, put a scandalous headline up there. People are going to buy that. People are going to click on that. Sure, I do it myself, And then I see a headline that looks kind of interesting and I click on it and I'm like, oh, that's crap.
Yeah.
But you know what I mean? You've clicked.
Yeah.
And that's the money spent. Not our money, but advertisers' money, So, so it's a lot of it is clickbait nonsense. And I do think there was a little bit of that scaremongering for clickbait. So what the nice guidelines, which were extraordinary. In 2015, when they came out, they literally turned the tide on attitude around menopause and HRT. So after all those dark years from 2002, we finally had a grown-up, comprehensive, this is what you need to know about menopause and HRT. And it really changed the industry for us. And the demand for menopause consultations and prescriptions for HRT started to exponentially go up after NICE. So we owe our lives to NICE. We really do. Now they're reviewing their 2015 guidelines, as they're compelled to do. And they want to recognize cognitive behavioral therapy as a really valid alternative or complementary resource for women in menopause. Why not do both? Why not do CBT and HRT? They're not saying one gets rid of the other. Yeah. So I say yes for CBT.
And is CBT easy to access in
No,
this
it's
country?
a nightmare.
Okay.
So that's the big
Do they have to go and see a psychologist?
No. So there's lots of avenues towards CBT. And probably the most convenient one is to do it with an algorithm, to do it online on your phone. You can buy CBT books and do CBT therapies and practices at home without a therapist. And if you can do that, well, then you can certainly do it on the phone with a kind of a bot.
Do you have any recommendations for that?
We are involved in Vincent's University Hospital, who are doing a sleep behavioral therapy algorithm called Sleepio. It's an app.
Sleepio.
Sleepio.
I'll put that in the notes.
In the UK, it's free. Anybody can access it. In Ireland, it's priced barrier.
Like everything?
But they're doing a kind of a project on it. They're researching its validity in Vincent's Hospital. So hopefully when the NICE guidelines comes out and encourages practitioners to recommend CBT as a first-line therapy, maybe our government will put some money towards accessible online. There's a really good app called Silver Cloud that all GPs can refer patients to in Ireland. That's usually a fee paying one, but you can get it free of charge through your GP. And Silver Cloud, it's mostly for mood, but it has some sleep stuff in there as well. Yeah, so there's lots of things you can do without paying 75, 80 euros a session for a cognitive behavioral therapist, if you can even find one. Yeah. Because no more than GPs, people in therapeutic practice, the numbers have gone down.
Yeah.
COVID I think it was during COVID that a lot of people, because face-to-face sessions and stuff were, blockaded, and not everybody loves doing stuff online. Some people retrained, they went into other areas, the numbers dwindled. So it's hard to get therapists in Ireland as well at the moment. It
really is. So other non-hormonal therapies for ladies like that?
Yeah, so now, everything else is kind of untested or off license, if you know what I mean. Lifestyle stuff helps. So if you're struggling with overweight, obesity, your vasomotor symptoms will be worse. No question about it. If you've unmanaged hypertension, your vasomotor symptoms will be worse. The flushes, the sweats, the sleep disruption they cause. Smoking is the kiss of death for everything, but it's particularly bad for menopausal flushes and sweats. So there are things you can ask your GP for help with within your lifestyle that can get the ball rolling in the right direction.
Vaping, is that better than smoking?
I don't know.
Okay, yeah.
I've heard both.
Yeah.
I've heard, obviously the addiction is to nicotine. So if you vape the nicotine and you remove the tar, are you somehow doing less damage to yourself? I don't know, is the answer. And from a flush sweat point of view, I'm not sure there's any data.
Okay.
Yeah. I know that pathology-wise, when you do an autopsy on someone who's died from lung disease, vapors don't seem to do much better than smokers. So now I don't know if that's actually backed up by science. I've just heard that anecdotally. I think nicotine replacement strategies make much more sense than putting stuff in your lungs.
Yeah.
So nicotine patches, nicotine gums and sprays would be, I would think, the first line. And certainly if you ask your GP, there's a wonderful HSE-funded program called quit.ie.
It's great.
And with a little bit of nicotine replacement support, when you're ready for it, and you do have to be ready for it, the goal there wouldn't be to completely cut out cigarettes, but certainly cut down. And even cutting down on smoking and vaping should help vasomotor symptoms up to a point.
Okay.
And as we well know now, the move is getting away from you're overweight, you're obese because you make bad choices and you're a weak person, to you genetically are vulnerable to overeating because your satiety centers are working against you and you need help to get your weight under control. That, again, there's a lot of knowledge and very few resources, but we're moving in the right direction for that. Yeah. So all of those things are beneficial to menopause, no question about it. When it comes to the prescribables, the only thing that actually has a license for vasomotor symptoms and menopause that's not HRT is clonidine blood pressure medicine. And it's the one thing that is particularly useless. So
Isn't it crazy?
It's medicine. I love it.
I know.
So the only thing that actually says on the product leaflet when you buy the blood pressure pill, clonidine, is for the control of blood pressure and also flushes and sweats in menopause. Don't bother with it.
But it doesn't actually work.
No. And if you don't have high blood pressure and you start taking a blood pressure drug, you can get I already have a bit of postural hypotension. I know the drama of bending down on my honkers to look at the price in the bottom shelf in the supermarket. And if I come up too quick, the whole room starts spinning. You don't want to be on a drug that does that to you. And it doesn't help. Not beyond, the first couple of placebo months that everyone gets from everything. We use a lot of drugs like oxybutynin. So oxybutynin is an overactive bladder drug, an anticholinergic that's used for people who find they have to pee too much or they get up at night to pee. We don't know why, but for some reason it significantly improves flushes and sweats. So fabulous. And if you don't get too much, it can cause like dry eyes and crusty mouth in the morning. If that's not too bothersome, you might get enough of a relief of flushes and sweats, particularly at night, that you get a good night's sleep. And a good night's sleep is
And if you just
key.
Prophylactically use eye drops and a lip balm, that's
and
fine.
keep drinking,
Yeah.
keep yourself hydrated. Most people tolerate it really, really well. So we love that. Antidepressant drugs help flushes and sweats.
Now, this is what I want to talk about.
I
Because
don't know
people
why.
say, I don't want to go on an antidepressant, but my doctor's prescribed me this, and they prescribe me antidepressants even though I've gone in with hot flashes. And they don't like the idea that they're on antidepressants, even though it's for something else entirely. So can we break that down?
Listen, it's a stigma, isn't it? Nobody likes to... I think the newer generations are much more comfortable to say, yes, I have a little bit of anxiety, depression, and I'm doing A, B, and C. I think a lot of people, I certainly, and I write about this in the book. Oh
yes, what's your book called?
Yeah, just the menopause.
Oh, Deirdre Lundy's book is out.
Yeah,
for years now, isn't it?
A couple of years. This time last year.
Yeah.
I just started getting really bad anxiety, but I didn't recognize it as anxiety. And I was like, what the hell is wrong with me? I was getting blurred vision and shortness of breath. And what I now look back and see is panic episodes, but I didn't understand it. And I certainly wouldn't have considered myself the kind of person who gets that stuff, whatever that means. There's a lot of judgment there because I'm type A and I'm in control and I'm bossy and all the rest of it. But of course, we are the very people for whom menopause brings that crap all crashing to the ground, So basically my perimenopause was manifesting as anxiety, depression. And I went on an SSRI, a modest dose of a kind of a standard one. And oh my God, I got amazing relief. So, if it works, do it.
Absolutely.
And there's no judgment. And I still take it. Now, do I still need it? Probably not. But I am so psychologically in love with my half of a tablet every day. And why rock the boat if I don't have to?
But even trying to wean yourself off a half a tablet could be difficult, actually,
I do feel a little anxious. I have tried in the past. And when I come off, even very, very slowly, and I'm not sure that this isn't psychological and not like physiological, I'm very conscious of the fact that I'm not taking it. You know what I mean?
Well, actually, I was looking at, there was the Pharmaceutical Journal released a study there a number of months ago, and they were saying that actually we've been coming off antidepressants for years the wrong way. This idea of having, then quartering, then coming off, or else every three times a week and then coming off. It should be hyperbolic. It should be literally like we should be going down to 1 mg a day, really, really slowly,
but
because
stay
you have
on that one.
Yeah, stay on that one. It should be. We should go from 5 to 4 to 3 to 1, over a period of months, to actually just be able to wean off properly,
That
so our
makes a
body isn't
lot
looking
of
for it.
sense.
But we can't do that because we don't make them.
They don't make
those
doses low enough.
And
Unless
then
you just use the piece of your teeth to kind of, or make little pellets out of it. You know?
Exactly, or else open them up, count the pellets out. And what they're suggesting that we could do is to dissolve the tablet and then pull out, so dissolve it in say 10 mils of water and then take out 1 mil.
That makes sense.
But it's off license, and it's like you're telling, and then it's
all
like,
good
you know, the way
is off license.
I know, but then it's like, oh, we're putting it into the hands of the patient. What if they take too much or little, or blame us? But
that's
it's
where
so
the
silly,
witchcraft comes in.
I
and
know.
I often say that to the doctors, that most of this is science, but a little bit of it is witchcraft.
Yes.
You know, because there isn't copious studies on all the different permutations and combinations of things we use to give people symptom relief and quality of life. But you need to be open to those things. A lot of people are so risk averse, and they're like, first do no harm, you know, but like doing nothing is harmful too.
Yes.
Yeah. So
absolutely.
It's a judgment, you know. But I think going back to me and my anxiety, depression is like my biggest hurdle to overcome back then was admitting that it wasn't a sign of weakness, that I wasn't a weak person, that this happened to me, that, you know, that it's not my fault, that it's just, it is what it is.
Yeah.
And I think a lot of people, when they hear antidepressant, there's a lot of judgment in there.
Yes. No, and the fact that it can help with hot flashes as well.
It's amazing. Yeah.
And
you
it's like,
can
how
use
does
tiny
it even?
doses, even very subtherapeutic doses of SSRIs, SNRIs, and where we tend to use it a lot in people with breast cancer, because I'm sorry, having never had it, I can't talk from experience, but I would imagine there's a certain amount of stress and anxiety attached to being diagnosed with breast cancer, not to mention all the treatments that go along with it and the ramifications they have for your life. So if you can take a mood drug that gives you a little bit of sort of, you know, resolve here and also gets rid of some flushes and sweats, what's not to love? That's assuming you tolerate it, and that's assuming you're willing to try it. But not everybody is, and that's fine. We move on to plan D, plan E, plan F, because we do have lots of other things. So gabapentin, which is a dodgy drug, and it's one of those drugs we're nervous to give people too easily because it is a drug of dependence, like a benzo, well, originally it came out as kind of an anti-epileptic. It's been used more recently for neurological pain, neuropathic pain. People who've had shingles and things use gabapentin. But again, in very, very low doses, it can help with certain aspects of menopause. It's really good for sleep. The only problem is it can give you kind of a hangover if you use too much of it. So the British Menopause Society recommends it in crazy high doses. We would never start somebody on gabapentin for menopausal sleep disruption at their recommended doses. We would give very subtherapeutic doses, almost like homeopathic doses. You're not too sure whether this is actually doing anything or if it's all placebo, but who cares if it works, you know? Yeah. And then gradually building it up if the patient needs more. But so that's been helpful. What other stuff do we use? We like Phenergan. We use a lot of antihistamine for sleep. So, you know, when the babies are kicking up with a bad cold, fresh cold or whatever, you give them a shot of Phenergan, you get a couple hours rest. Do it to yourself. You can take Phenergan going to bed at night.
Okay.
And it can actually help you kind of get off to sleep when sleep is your core problem.
Actually, some questions that come in. Histamine allergy, is that a thing?
Yeah. Louise Newson talks a lot about histaminic reactions in menopause. So inflammation in general can be a problem for a lot of people. And so some people have very hyperactive immune responses to things. Histamine is one of those elements that gets signaled when you're having a reaction to something, you're sensitive to something. And it seems to go awry in menopause. I don't know what it is about estrogen, progesterone, testosterone, and immune response, but there does seem to be a connection there. What it is, I don't know.
Does that manifest in the joint inflammation and that and the pain? Yeah.
So antihistamines are often used quite in copious amounts in some of these private UK menopause clinics with good result, you know. So, but we don't use them for that. We mostly use them for sleep.
Okay.
Yeah. There isn't enough data. You know, everyone has to have a comfort with the drugs they use, like over-the-counter antihistamines for sleep improvement. Why not? But massive doses of antihistamine because you've identified somebody as having mast cell activation syndrome or something, that's not for me as a GP. That's for somebody who's got immunological training.
Okay. Okay.
I think.
Yeah. And then is there any other non-hormonals that you would recommend
what
before we
else
go on
do
to
we
the
use?
HRT
I'm
story?
trying to go through my list. I have this big list of stuff. We certainly are pretty liberal with our recognition of genitourinary syndrome of the menopause. So anything got to do with the vulva, the vagina, the urethra, the bladder, the pelvic floor, you got a problem down there, you need estrogen. So almost everybody with breast cancer, we give local vaginal estrogen to.
Okay, and I'm delighted that you said that. Okay,
Yeah.
It's one of
It's
the
a
main
contentious
things. It
issue.
really is, and
Yeah.
so many women, and young women, old women, doesn't matter. If you have issues with your vagina, your vulva, your pelvic floor, estrogen can really help. Localized estrogen. So that's your
Absolutely.
Vagifem and your Ovestin creams, yeah.
Mm-hmm.
But they are being told
I know.
by society, but also by their GPs, that because they've had breast cancer, that they can't use it. Can we please dispel that myth?
The difficulty is that if you read the leaflet on any local vaginal estrogen product, at the moment in Ireland we have 4. We have Vagifem and Vagirux and Invagis. Those are the 2 pessaries. We have Ovestin and we have a new gel called Blissell. Okay, so you can get a prescription for any of those products in Ireland, and they're all amazing for vaginal, pelvic floor, bladder, vulval symptoms. They all say do not use if you've had breast cancer, even though we have an abundance of guidelines to say that it's perfectly safe to use them if you've had breast cancer. And the reason is because, as always is the case with product information leaflets, they are very much cover my behind, let's not make ourselves vulnerable. That's their focus. And there isn't, and they're right in that they can't claim that these products are 100% safe because there isn't a plethora of evidence out there. There has never been a massive trial where thousands of ladies were enrolled after a breast cancer diagnosis, and half of them were given placebo products for the vagina and half of them were given estrogen products for the vagina. And then we watched them for the next 10 and 20 years to see whose cancers returned or spread or whatever. So there's no data. But we just know empirically from our anecdotal use of these products that local vaginal estrogen is exactly that. It works in the vagina and around the pelvic floor with a tiny, if any, absorption across the tissues into the circulation. So local vaginal estrogen, in our opinion as experts, is not HRT. It's not going to help flushes and sweats. It's not going to help mood because it doesn't get in the blood supply. Now, that's a little bit of a lie insofar as when things are really dried out down there, initially, when you start to use the products, you may well get some systemic feelings from the estrogen because there's no barrier in your vagina to keep the products local. They're moving into the blood because you've got no flesh down there. But after 2-3 weeks of using the products, as everything starts to become more juicy and replenished, your now normal, healthy vaginal tissue acts to trap the estrogen there and not let it move too much beyond the pelvis. So there's no reason on earth why somebody after breast cancer can't have local vaginal estrogen. Moreover, if they need it when they're, say, 45, 50, they're going to need it more when they're 60, more than when they're 70, and more than they're 80. So they should be given an indefinite prescription for those products. But again, the product information leaflet will say, use the lowest dose for the least shortest amount of time, which is completely counter
It's
to.
so against because once the estrogen's gone, ladies, it's gone. It's not coming back.
No.
There's definitely a case for women, and we see it all the time in nursing homes. UTI after UTI after UTI that could very well be managed by just localized estrogen.
And there are a few tiny little studies where nursing home residents who were incontinent and wearing adult continence products were having a little bit of local vaginal estrogen ointment applied, maybe once or twice a week, and when they were being toileted, and the UTI rate just dropped away to half nothing. So I can see an avenue for it becoming standardized care in nursing home for people who are brave enough to think outside the box. And a lot of this is outside the box thinking because, again, there are no big randomized controlled trials, which is that's how we gain confidence in prescribing in medicine, but it's also how we change the product information leaflet. So let's assume that's never going to happen. We need to empower the people to whom we prescribe the local vaginal estrogen by saying, if you choose to read the leaflet, be advised that a lot of what we've just talked about will be, there'll be conflicting information in the leaflet. I'm right, they're wrong. That's easy to say. Like, I mean, a GP or another doctor could say that about something and we could disagree. So that's not fair to the patient to make her be between a rock and a hard place, you know. But so we steered them towards British Menopause Society guidelines, and British Menopause Society guidelines are very clear that the benefits far outweigh the risks for local vaginal estrogen in women. There is only one tiny subgroup that we do have a bit of pause about, and those are women who are actively taking aromatase inhibitors. So ladies who are currently swallowing a letrozole or something. The way in which letrozole breast cancer medicine works is it prevents other hormones in the blood and tissues from being converted into estrogen. The goal there is to suck every drop of estrogen out of every tissue and the circulation.
It's actually awful,
it's
though, isn't it?
It's a rotten drug. Now, it's a good drug for breast cancer survivorship. Don't get me wrong, but talk about side effects. Like some people are quite affected by it. The problem there is if you do get a little bit of seepage across the vaginal membranes in the early phase of starting local vaginal estrogen, will this somehow undermine the goal of using an aromatase inhibitor? With tamoxifen, we don't care because the tamoxifen drug works in a different way. It blocks the receptors at the breast cells. So even if there is a tiny bit of estrogen leakage out of the vagina into the blood with somebody on tamoxifen, it's unlikely to have any impact. But again, we don't have any studies, but scientifically it don't make any sense, you know?
Yeah.
I also don't think aromatase inhibitors are going to be grossly undermined by local vaginal estrogen use if you use it correctly. And this is the problem. If you use it for short bursts, feel better and stop it.
Oh, I know.
Then go back to it a couple of weeks later, do the same again. You are raising your systemic estrogen levels because you're doing the initiation high dose phase of the vagina treatment over and over again. That doesn't make any sense. That's actually silly. So if you are on an aromatase inhibitor and you do opt to get some relief from your vaginal or pelvic floor or bladder symptoms, you should be on the vaginal estrogen low dose all the time. Do not default. Because if you let yourself go back to square one and you need 2 weeks, 3 weeks of daily estrogen, you are pumping up your hormone levels. And if you have a very highly estrogen sensitive tumor history, you don't want to do that.
Yeah, and the actual way to use it is every night for 2 weeks straight, and then you drop down to twice weekly. Exactly. And some women need it 3 times weekly. It kind of depends. It's kind of
the lowest dose you need.
Yeah,
but it's consistent and constant weekly use is what keeps you well. It's not a condition that you use it. It's not like antibiotics. You don't use it till you get better and then you don't use it again for a year or two. It's once you need it, chances are you're always going to need it. And certainly for as long as you're on the aromatase inhibitor, you're going to need it because that's the problem. Aromatase inhibitors drain so much of the estrogen out of the vaginal tissues and the pelvic tissues that you can get a lot of genitourinary symptoms when you're on them. Yeah. But like, everybody has their own attitude about this, you know, and the guidelines from the British Menopause are a little bit more guarded around concurrent use of an aromatase inhibitor and local vaginal estrogen. There was a study published in like 2016 where a very small number of women were followed after breast cancer diagnosis, something like 20 people, 30 people, and they found one extra case of breast cancer recurrence among the ladies who used the local vaginal estrogen. Okay. So it's literally based on that study that we have this concern about the combined use of estrogen and aromatase inhibitors. But everybody is an individual. That's the overriding recommendation in the British Menopause. Each person is an individual. Each person can make her own decision, their own decision, based on their need at the time. And if somebody's symptoms are really marked and they are not getting relief from other moisturizers, lubes, whatever, they need local vaginal estrogen, and that's just all there is to it. Or go back to their oncologist and say, I cannot deal with my AI. Is there something else we could talk about? Usually tamoxifen.
Okay. Yeah. Women that have a family history of breast cancer being told that they can't use HRT.
Not
so
true.
either
not true. Yeah.
a mom or a sister or an auntie, please.
So family history of anything is not an absolute contraindication to using HRT for menopause relief. Okay. Family histories play a role in some of what we do in women's health. So if you had a family history of blood clots, particularly in pregnancy or when you use the contraceptive pill, I would probably not prescribe you the contraceptive pill because I would be afraid that you've inherited whatever genetic predisposition there was, and I don't want to kill you. Okay.
Okay.
And I would probably look at other forms of contraception before I would automatically go for the combined for an estrogen based contraceptive for you. That's different. HRT is it's not the same as that. So family history of blood clots, family history of breast cancer, family history of womb lining cancer. These are important issues to discuss and maybe explore as part of a general practice consultation. But none of them are hands down contraindications to you considering HRT for menopausal relief. Okay. So if somebody comes in and says, well, my GP said I can't have HRT because I have a history of family history of breast cancer. I say, tell me about this family history. My granny got breast cancer when she was 65. I say, it's not that I'm not sympathetic. It doesn't matter. So older people getting diagnosed with breast cancer is normal. Breast cancer is the commonest cancer in women. If you're lucky enough to live into your 60s, 70s, 80s, 90s, and beyond, there's a good chance a good few of us are going to be diagnosed with breast cancer because it's our cancer. Does that mean you're high risk? No, it does not. But if your mom was diagnosed with breast cancer when she was 35, we need to talk because that is a very strong family history, and you yourself might have a higher than average risk, and you might need earlier screening. You might need to be aware of some of the lifestyle factors that you might be able to modify. Will it stop me from giving you HRT if you have premature menopause? No, it will not. But it's a separate issue that needs to be teased out. So there's family histories and there's family histories. And we would never, hands down, discourage somebody from considering HRT just because they had a family history of breast cancer. But 2 or more first-order relatives, that means a mom, a dad, or a sister. Well, forget a dad. Anybody with a male in their family with breast cancer is high risk and needs to go to a familial.
That's actually really interesting.
Yeah.
Can we talk about that? Because the BRCA gene is...
It's in men and women.
Yeah. And people only think it's in women.
Sometimes men carry it and we don't really see too much cancer manifestation, but sometimes men get breast cancer. And if you had a dad or a brother or an uncle or whatever, a blood relative that had a breast cancer, male, then the family needs to be tested. And the sad thing is we know it's linked to BRCA, but it's probably linked to other genetic cancer mutations, but we just don't have names and tests for them all. So a lot of times people will say to me, my mom got breast cancer when she was in her 40s, and my sister was just diagnosed with breast cancer last year. I've been tested, and I'm BRCA negative. That doesn't mean much to me. You probably do have a gene. You just don't have a gene for which there's a test. Okay. You have a very strong family history of breast cancer. You should be vigilant about self-examination. You might consider going to one of the familial, excuse me. You might consider going to one of the familial breast cancer screening services because your risk is so high. But if at the same time as doing that, you're also afflicted with menopause disruption and you're interested in exploring HRT, there's no reason why you can't use that because HRT does not cause breast cancer. Family history can increase your personal risk of breast cancer 3, 4, 5-fold. So strong family history trumps being overweight, drinking, being sedentary, taking HRT. You're already of significant risk. And those risks they're not cumulative. So it doesn't double if you go on HRT and then quadruple if you drink wine. You know what I mean?
Yes.
You pick your worst thing and that's the thing.
Okay.
So if you've got a rotten, strong family history of breast cancer, you got to watch your breasts because that's your worst thing. But does that mean you're not allowed to drink a glass of wine? Of course you can. Does that mean you can't use HRT if your menopause symptoms are afflicting you? Of course you can. Yeah. But, you got to do the homework as well.
So if you had a mum me, right? My maternal grandmother had breast cancer and died at 52 after having 10 babies, and probably spending most of her life
estrogenized.
Oh my goodness.
Yeah.
My mum had it in her 50s. So it's just about me minding myself, checking myself, and still enjoying my glass of wine, which I do.
There may be a genetic element there because there's a granny and a mom. Like that's not that common. And those are young women. They weren't 70 or 80. So definitely being breast self-aware is key. Going for mammograms. Sometimes they will start doing screening mammography well before the 50 birthday that we typically do for the population, because there is a stronger family history there. Why not? You know, would I get a genetic screen? Probably not, because it's not that strong. I don't know that there's a gene out there that's linked to those midlife breast cancers. Maybe there is. I don't know. I really don't know that much about genetic breast cancer screening, to be honest with you. But would I deny myself access to HRT based on that family history? No, I would not. The real discussion is, how will I feel if, in the unlikely but unfortunate event that I do come down with and am diagnosed with the breast cancer, will I now look back and say, crap, I should never have had that glass of wine. I should never have gone on HRT. I mean, I would, you know, because I'm an awful pessimist. I'd be like blaming myself for everything, you know, blame myself for global warming. But like, that narrative is individual. You have to have that conversation with people. You know, how do you think you would feel if, knowing that you really needed some menopausal support now, and that you used hormones with our encouragement, and then in later life you were diagnosed? Will you blame yourself? You know, because we don't want you. We wouldn't like that to happen. And if you feel you would, then maybe we should look at it non-HRT alternatives, you know.
But some women will say that, you know, they had breast cancer and they got the treatment, and actually how they feel post the treatment is so much worse.
I know.
So it's almost like,
treatments are not easy.
No, and it's almost like the treatment has given them another illness, or they feel it's an illness. You know, so it's true. It's so difficult for them, you know.
Yeah, and I don't think that's addressed as well as it could be in oncology services. You know, I heard a man on the radio today, a fabulous urologist, talking about dealing with prostate cancer in James's hospital, and his whole focus is the aftermath of care. Yeah. Like, I feel in some of the services we've engaged with that patients are told, the attitude is that we've cured your breast cancer, you should be grateful and you're lucky to be alive. And the fact that your quality of life is in your shoes, that's just a natural consequence of survivorship. And although there are wonderful oncology nurse supports in place, I don't know that they're as well versed with dealing with their ladies as we are, having gotten them through the back door. You know what I mean? So like 80% of I'd see 1,000 patients a year, and 80% of them have had breast cancer and have not been well supported in either the cancer services or beyond after their cancer treatment. Like, why can't they do what we do?
Therein lies the question.
Yeah.
I want to talk to you about the new drug that's out for hot flashes.
We're excited about that. I'm very excited about that. So there's an entirely new stream of pharmaceutical coming online this year and next year that looks now specifically looking at flushes and sweats, vasomotor as we call it, which shouldn't be minimized. Like, their impact on quality of life, sleep disruption, fatigue, energy, mood, immeasurable. So to correct flushes and sweats in somebody who really suffers from them is life-changing, absolutely life-changing. So there is a whole cohort of drugs that works on a collection of neurons in the brain called the candy transmitters, KNDY, if you want to Google it and look up what the science is, because I go to the lectures, but I'm not really.
They're fun looking.
Yeah. So basically, they're centers in the brain that control flushing and sweating, and core temperature versus skin temperature and stuff like temperature perception. And when our body thinks we need to start to sweat to wick off heat, you know, that kind of a thing. So they bypass sex hormones altogether. So these are neurotransmitter modifying drugs, okay? They call them the neurokinin 3,4 antagonists, NK3,4 antagonists. And one of the first ones ever developed is called fezolinetant.
It's a lovely little name.
I just call her Fez.
Yeah.
But the company that makes her over here is going to call her Veoza.
Yeah.
And she is an oral tablet that you take every day. She don't do nothing to your ovaries. She don't do nothing to your breasts. She goes straight to your brain and shuts down flushes and sweats.
She's bloody expensive though, Deirdre.
Out of control.
How are we going to get it onto the drug schemes?
We need to. The company that makes her is going to have to petition the pharmaceutical decision-making people in the HSE to say we really need this product to be controlled, covered by drugs payment and medical card. And I think they will eventually because there's nothing else like her.
Because she's $580 for 30 tablets.
Yeah, in Ireland, it won't be that high. It'll be about maybe 50, 60, 70 a month. That kind of range. It'll be under 100 a month, which is still a considerable amount of money. But I mean, even if you got it on the drugs payment, it'd be 80 a month. So, it's not that bad. But that's what I'm expecting. Like I'm very honored to be involved in the decision making around launching it and how to get drugs payment approval and medical card approval with the company that's releasing it here, Astellas. So fingers crossed, we should have it by early summer.
And that'll be great for these breast cancer patients that you're talking about, will it?
Yes and no. It depends on who you talk to.
Okay.
So unfortunately, this particular neurokinin antagonist was never trialed in breast cancer survivors. So it will say on the product information leaflet that it won't say that it's licensed for use in the control of flushes and sweats in people who've been diagnosed with breast cancer. There is another version of this medicine coming out next year, which is specifically being trialed in people who've had breast cancer. In fact, part of the trial is happening in Ireland at the moment, the OASIS 4 trial. Professor Donald Brennan is the head of that, and we helped recruit for that trial. And they're getting amazing results. So it'll be another case of a drug we know that works, that hasn't yet been proven to be safe for breast cancer survivors, but is available to them if they choose to take a leap of faith.
But it would seem if it's only working on the brain and not nothing to do with the ovaries or hormones, it should affect anyone that has hormonal.
But again, it'll be off-label. Because we don't have a trial to confirm its safety in breast cancer survivors. So that's what I'm going to say to my patients when I get my hands on it and say, and we'll probably still be very much focusing on the cognitive behavioral therapy, the SSRI and SSRI mood drugs, the oxybutynin, the GABA, the whatever the hell's out there. But also we have this, if that's something you'd be open to,
Would you be open to Vagifem being OTC for women?
It is. It's OTC in the United Kingdom.
In the United, but not
and
here in
Ireland. And I don't see why on earth it shouldn't be in Ireland.
Yeah.
Well. You can drive to the north and buy Regina or Regine or something it's called over the counter, and it's Vagifem basically.
Yeah.
Absolutely, it should be over the counter here. Yeah.
Would you say it should be over the counter after an initial consultation with the doctor, or no, just go for it? Yeah.
Yeah.
I do often think, and I say this a lot, that if men's penises were drying up and falling off or not fit for purpose in the terms of the sexual dysfunction,
plenty of products
I think there would be vending machines at the end of every street with replacement therapy for whatever the men needed to rub on their penises. It is so backward the way women's health is managed, isn't it? Really?
Yeah. Like, I mean, that's what they were talking about today, that, if you need significant prostate cancer surgery, there's a good chance you're going to become impotent. That has a big impact on people's decision making. I don't know that anyone going into breast cancer therapy has the conversation about, and by the way, our treatments will very likely give you one or other of these joyful symptoms.
Yeah.
Because women are soldiers, women are stoics. They'll be like, I don't care, I need to survive. I have children, I have family. I need to do everything in my power to get rid of this cancer and carry on, and damn the consequences. And unfortunately, which is good because, but then we're not lippy enough to say, thank you for saving me from the cancer. And by the way, I have untenable side effects from your treatments. And what are you going to do about it? Because they don't do nothing, Well,
also, and we were talking a little bit earlier about people that may come to you and they haven't had any success with their own GP, who may have been an amazing GP for most of their lives and got them through an awful lot. But when it comes to the menopause, the education just isn't quite there.
Sometimes,
and they feel disloyal then about...
Yeah, I have had that experience so often where a patient will come in. Here's a common one. So somebody was told, you can't have HRT of any kind because your mom had a blood clot. And I'll be like, well, you've had 4 kids and you spent 12 years on the contraceptive pill. Your personal risk of blood clots is 0. So I would And even if you had a clot on an oral contraceptive pill, you could still use HRT. You just have to be very careful about making sure the estrogen dose is low and that you're using it through the skin. And so I'll happily write you a prescription. And they're like, oh, but I wouldn't like to upset my GP.
So I'd rather deal with all these symptoms rather than upset him.
Take a guideline-supported treatment because they don't want to upset the GP who gave them erroneous information. That is not an uncommon attitude in this country.
Is it an Irish thing?
Nah, I don't know. Maybe it's a Catholic thing. I don't know. It makes me sad is what it does. You know, like who's in charge here? You know what I mean? I suppose back in the day where you had a much more intimate relationship with your GP, house calls, birthing babies at home, I could kind of get that. Whereas nowadays, you know, most surgeries have more than one doctor. If one doctor has a kind of a strong attitude, right or wrong, you could always make an appointment with one of the partners, you know, or assistants. You can always go to a family planning clinic, Well Woman Center, for independent, well-balanced advice, you know.
And that's really interesting because I think people associate Well Woman Centres with contraception only.
Oh, yeah, that's their primary deal. Obviously, that's their focus. But, I mean, they do all women's health. Like,
yeah,
they do your pessaries, some of them. They do your smears, do your breast examination. You know, so say you don't have a great situation in your GP and you don't feel your women's health stuff is being catered for. You know, people get a bus to Dublin, a train to Dublin to buy a pair of shoes for a wedding. So, like, why couldn't you come up twice a year to the Well Women Centre? And
well, that's it actually too, because there is a dearth of kind of practices in the West or the Northwest, or even, you know, down in Munster that can really help people that are living in rural areas.
Yeah.
So where do they go to when they need to access care?
There are Well Women and family planning centres in other regions, but the majority are in Dublin City Centre.
Is there a resource they can look up, like a Google, like menopause clinics that are, you know, is there an actual...
There should be, there isn't.
Okay.
But certainly if you look at the IFPA, Irish Family Planning Association website, or the Dublin Well Woman Centre, DWCC, whatever it is, Dublin Well Woman, I think they're called. The directors there, Shirley and Katrina, are enormous, wonderful women's advocates. They're buddies of mine. When we used to do a lot of GP training for the Irish College of General Practitioners, I never had an event that they weren't part of it, because their knowledge base is enormous, and they run those two services. So their wisdom guides the information you get in those services, and you could do a lot worse than have a consultation with one of those doctors, you know.
Okay.
I love them, and I learned my craft there, so I would strongly recommend them for people who live in areas that don't have a lot of choices.
Yeah. Okay. In terms of HRT, what is the cut-off point for women? So first of all, I wanted to ask, how long should they be on it for? Can they continue on it for longer than 10 years if they really feel that they need to? And then also, could a woman who's 68, still experiencing symptoms, feel she wasn't looked after during menopause, she went through that awful period of time where could she start it?
Okay, I'll do the first one first. Okay, so duration of use depends on your goal. If your goal is just to get some meaningful relief from your menopausal symptoms, then most people won't stay on HRT for too long. 2, 4, 5, 6 years would be about the average. And we know this from prescription data, because you don't notice people who don't come back to you as much as you notice people who do come back to you, if you know what I mean, in general practice. So if somebody who you have initiated on HRT has done quite well and just has been coming in for a few years getting their prescriptions renewed, the recommendation is you get your blood pressure tested annually. That's it. That's all you need to do. For estrogen and progestogen, for testosterone, you need blood tests. Then you might just not notice that they didn't turn up after a while. But if you look at the prescription purchasing data, you'll see that most people don't stay on HRT very much longer than 2 to 5 years, because they come off and they realize, actually, I don't feel quite so crap as I did when I first went on it, so I don't need it anymore. And that would be the general attitude towards HRT. If you do find that every time you try to come off, your symptoms are still there and are severe, low-dose HRT for an extended amount of time for perceived disease prevention, then obviously the longer you stay on it, the better it is for you. And we do have data to suggest that people who start HRT early enough in their menopausal journey, within 10 years of their final period, who go on it maybe for symptom relief. The longer they stay on it, the lower their risk of cardiovascular disease.
When you say within 10 years of their final period, do you mean before or after their final period? Okay.
So if say you had periods up to like 52, which is the average age, and then you went on HRT around 58, 59, you will get cardiac disease prevention, because you're within 10 years of your last period.
Okay.
And the depletion of estrogen hasn't had a good 10 years head start on you to cause hardening of your carotid arteries, your cardiac arteries, to cause all the changes in the cardiovascular symptoms that become accelerated after menopause.
Okay.
So cardiovascular disease is relatively less common in younger women than it is in older women because estrogen is cardiac protecting. When you lose estrogen, your cardiovascular system suffers for the loss of it. But if you can replace that estrogen and, more importantly, maintain that estrogen for long periods, you get primary prevention of cardiovascular disease. But there isn't enough data to recommend that for the population at the moment. So some people, and I'm one of those people, have looked at some of the studies and some of the recommendations and said, in my family, cardiovascular disease is the primary killer, although for the most part we're very long-lived people, thank God. But those who do die young from angina, cardiac failure, cardiovascular disease, heart attacks. So I needed HRT in younger life for symptom control, but I've opted to stay on very, very small doses of HRT as I go into my 60s. I'm 63 now, for cardiac protection. Now, that is not a global recommendation, but if someone decided to do that and she had no reason not to, I would happily facilitate
What does low dose look like?
I take a half of 50 patch.
Okay.
Yeah.
Cut diagonally, I hope.
I'm actually cutting it perpendicular to the peely-offy thing.
Okay.
I can barely get the back off
I know
of it
it's
with my
hard,
fingers.
isn't it, with when you're doing it that way.
And that's a choice. And I have a lot of patients who have chosen to do that, and that's absolutely within their right to do so. Does that expose me to a slightly, potentially higher risk of being diagnosed with breast cancer? Maybe. But relative to all the other stuff that has impact on breast cancer diagnosis risk, I'm willing to take the shot. I'm willing to take it,
Okay.
But that's my decision. It is not uncommon for people, particularly nowadays where menopause is getting more airtime, in the media and what have you, to say, I'm 65, 68. I went through a really bad menopause, but some of my symptoms, they got better, but some of them never got better. And particularly my flushes and sweats still can be an issue. That's not that uncommon. And the first thing we'll say to those people is, well, let's look at lifestyle stuff. Let's look at other diseases that we know affect flushes and sweats. People with overweight, obesity get a lot more flushes and sweats. Like I said to you before, people who have uncontrolled high blood pressure, people who have concomitant, like a lot of cardiovascular risk, like the blood pressure, like the strong family history, they get extended experience of cardiovascular or of vasomotor symptoms. So I look at flushes and sweats in later life as a red flag for, let's check your heart. Let's check your circulation. Let's see what we can be doing about your cholesterol, your blood pressure, your physical activity, your weight, your smoking history, your drinking history, all of those modifiable things. And if at that stage you do decide to try some HRT for symptom relief, absolutely. There is no age barrier. So there's no upper limit after which a person is not allowed to try HRT. But I wouldn't consider it responsible to just do the HRT for someone with persistent flushes and sweats. I would be looking at those other factors that make that an issue for someone's life, like cardiovascular risk. If someone had no menopause symptoms and came into the surgery at 68 with new onset flushes and sweats, look for lymphoma. Look for disease. It's very unlikely to be menopause having just turned up for the first time at 68. Look for other causes.
And this is why the whole discussion is so nuanced, because as we get older, we're more at risk of other diseases. We're more at risk of mood disorders even.
Sure.
And if it is that they think they're irritable, they're moody, they're low, they might have a bit of depression there. There's so much more maybe going on there. We can't necessarily just say bang them on the HRT and that'll be fine.
No,
Sure,
and that would be bad for us as women to do that. You know, like I'm lazy. Hands up, I am among the laziest people I know. If there's a pill that could fix something that didn't involve me having to walk and not eat what I want to eat, eat good food, I'd take the pill. You know what I mean? It's human nature.
Yeah.
But
it's so refreshing to hear you say that.
I am so lazy. That's not entirely true. Like I was sedentary my whole life, and then I have these two crazy friends who are hill walkers, and they co-opted me into their little group about 15, 20 years ago, around the time I got the anxiety, depression symptoms, and I used it then as a sort of a therapy for that. Oh my God, I'm completely addicted now, So I am so much more active and always outside, because I think being outside is so beneficial to mood, all weathers. Like, we are maniacs, but yeah.
You go tromping up the hills.
Yeah.
Actually, this just brings us into it. I have to talk about it anyway, but it's the weight in menopause and that middle age spread and that tire that women who may have been slim all their lives, eat well, they can't get rid of it, and they actually beat themselves up about it. Can we just talk about that?
It's not your fault. Yeah. I mean, there is actually a website called It's Not Your Fault when it comes to weight changes, weight gain and stuff. And that's true of people who've been heavy their whole lives, and it's true of people who get a menopausal related weight gain. So when it comes to people who've generally been slim and had pretty healthy BMIs, noticing that they are gaining weight without explanation, it's because of menopause. So menopause affects your metabolic rate, and the food you normally were able to process, digest, and burn off is no longer going away. It's not being utilized for energy. It's actually being converted into stored fat. You're gaining weight, especially truncal weight, so around the midriff, which is the most unhealthy of all the weights. Like big ass, big hips, not going to kill anybody. In fact, it protects you from falls, Thank you, Mom and Grandma, for my big ass and big hips. But you do not want middle weight, around between your pelvic bone and your breasts. Because if you're fat there, that means you got fat on your liver, you got fat on your heart, you got fat on your spleen, on your bowel, places where you don't want it. And that is because of menopause. Now, HRT will not fix that. But what it might do is give you a better night's rest and a better, less fatigue and more energy to take steps to address this change in your metabolic rate, which means you're going to have to eat a little less and move a little more. And there is nothing else for it. Now, eating a little less is like me telling a 40 cigarette a day person to just stop. It's impossible. You are addicted. Like me, I had a very high satiety rate. It took a lot of food to get me feeling full. So I ate more than I needed to be a healthy weight. I've used SLG1s, and with enormous success, I've lost 5 stone in the last 18 months.
Actually, I did think, but I don't like commenting on people's weight and saying, oh my God, you look great. But and it's not that people look great because they look slimmer, but the last time I did see you, you were heavier. And so you've used those.
Ozempic.
Yeah.
Okay,
and you find it.
And now I'm one of 4 siblings. We're all on it.
Okay.
In America, it's considered irresponsible not to put somebody with obesity on a satiety control drug, especially when it's impacting things like their blood pressure, pre-diabetes, diabetes, their ability to engage with physical activity.
And do you prescribe that for your patients?
I can't in Hollis Street because we're a gynecological service.
Okay.
But I would strongly recommend people with resources to talk to somebody. There's a lot of private weight management groups emerging out there who are more than happy to engage, but are obviously at a cost, and you do have to have resources to do that. The biggest difficulty, as we all know, is accessing the drugs because the demand has outstripped, like it happened with HRT a couple of years ago. All of a sudden, it's like, boom, I want this, because it works and it really improves quality of life. That happened to HRT. We eventually found a happy medium, and now we have all the HRT we need. That will happen to the Wegovy's and the Ozempics, but it's going to take a little time.
It will take time, And we also, there's very strict criteria for it.
At the moment, but I think when the supply is greater, like the frustration I hear from GP colleagues, they're meeting people whose joints are destroyed, whose cholesterol is off the charts, whose sugars, HbA1s are messed up, who really need therapeutic intervention for weight management, but because they're not actually diabetic, there is this hesitation to prescribe products for them. And then when they do prescribe, the people can't get it in the pharmacy. You know?
Yeah.
Priority is given to diabetes. I get that. I fully get that. But that's an issue because of short supply. When we get the supply, I think those barriers will be removed. So there's hope. There's hope for everybody out there, you know?
Yeah, and I think, you know the way you said eat less and move more, and that's like saying stop smoking or whatever.
It's impossible.
It's also, you know, we say, oh, women that are getting older, they just eat, you know, 200 less calories a day and that will get rid of that weight. But to what end? Irritability, crankiness, actual, you know, you're feeling starving as well.
I know. And then the guilt. I think the guilt is the worst thing. You go to bed every night, God, cataloging what you put in your mouth. And like you're a bad person if you ate that chocolate bar, but you're a good person if you, I mean, honest to God, I'm talking from a lifetime of overweight, obesity, like the lift of guilt for having metabolic doctors saying, well, you were just born, the amount of food it takes you to feel sated is as much a part of your genetic makeup as the color of your eyes. It's not your choice to need to eat this level to feel full. It's built in. Mm-hmm. What we're going to do with these medicines is to make you feel fuller quicker. That's how gastric bypass works.
Yeah.
And you will just, you'll know what skinny people feel like when they go to a restaurant and they leave half their food and you're like,
how do they do that?
She left half her dessert. What's wrong with her? You know, and you're like, slide it over here. Yeah. Dessert, you know, like, which I do, or I did.
You used to.
Yeah, I used to. Now I'm like, oh no, I don't want to.
That's it's remarkable though, isn't it? But it is good that we're having that conversation.
Yeah,
you know, it's very good. Testosterone,
okay,
libido, and all that jazz.
Yes,
can we address this, please?
Yeah, it is absolutely true to say that the ovaries make a lot more hormone than just estrogen and progesterone. There's about 8 or 10 different ones, at least that I'm familiar with. There's probably more, you know, but I'm not that much of a scientist. But one of the more significant ones for menopause is testosterone. So we make 4 different types of androgen in our ovary as females, and one of them is testosterone. And there is a lot of data to suggest that people who go through menopause who notice a big change in libido, so desire, fantasy, orgasmic ability, part of that could be because of a fall off in testosterone. Now, it's not as obvious as the studies we have about estrogen and progesterone, or estrogen particularly. And what I mean by that is testosterone production naturally drops in biological females from around their mid-20s, early 30s. Why, I don't know, but it just does. So it's not a menopause-specific issue. It just tends to be more talked about around menopause, I think. So if I meet somebody with premature menopause, anybody under 40 who has proven low ovary hormone production has got POI, premature ovarian insufficiency. And those women absolutely need to have a specialty consultation about their hormone status. We often find those girls notice a low sex drive, lower than it used to be. So with them, we would usually recommend supporting their estrogen levels, adding in progesterone if they have a womb, and we always discuss testosterone replacement for them because they're so young, the need is likely to be quite great there. Not always, but often. With normal perimenopausal, menopausal women, 45, 55 plus, if somebody says to me, I always say, what are your top 3 worst symptoms of your how your menopause is affecting? If libido is in there, we need to discuss testosterone. Now, sometimes people say, I find that my sex drive is better now that I sleep well. I look a bit better. You gave me that vaginal estrogen. It's not sandpaper on fire down below anymore. I'm much more comfortable to have penetration, which means I can achieve orgasm again without too much discomfort. A lot of those ladies don't need testosterone because the estrogen and progesterone have given them sexual comfort. It's all they needed. But some people want that drive. They want to feel
horny.
Yeah, that's the word. They want to initiate again instead of being a willing participant. You know what I mean? Yeah. And sometimes you need a little testosterone to do that. So yes, we're very open to prescribing testosterone for that reason. Now, I've seen a lot of media talking about, it helps with brain fog, it helps with energy levels and muscle definition and sarcopenia. It might, but we don't have any studies to actually support that yet. So at the moment, if you're going by guidelines, the guidelines are not there for using testosterone in midlife women for any other purpose than to improve sex drive. That's what.
And
we
what
use
are the
it for.
stats like for the people that would have low libido and you put them on it?
Pretty good.
Is it okay?
Yeah, a lot of people say it's a game changer. Others say it didn't do anything. I mean, you know what people are like. We're a very complicated organism. Our sex drive is affected by a lot more than our testosterone levels, you know. So like if you hate the living sight of him, testosterone's not going to really do much for you. If you're exhausted because your work is over demanding and your kids can't get out of the house and now your mother needs help every day, you know, your interest in sex is probably one of the first things you're going to throw out of the lifeboat because it's not that big of a deal to you. In many cases, not everybody feels like that, you know.
I often say something that's really good for desire is if your partner empties the dishwasher. Gratitude. And helps you a little bit around the house.
Gratitude is very sexy. It really is. You know,
Absolutely.
Thanks for thinking of that.
Yes.
Yeah, absolutely. You know. So.
And, you know, if women did actually just take it upon themselves to demand more help in the house, you know, their partners might see a massive difference in their sex drive.
Where you see it is the young girl. So you're 25. You've been diagnosed with POI. Say you had treatment for like a cancer or something, you know, Hodgkin's lymphoma, whatever. And they've irradiated you and now you have no ovarian function. A lot of those poor kids will, some of them will have quite marked symptoms, some not so many, but a lot of them will have a fall off in sex drive because they have no testosterone left. So those girls really respond very quickly to testosterone support. It's a little bit more nuanced, I think, in older women who've been in long-term relationships, who have a lot of social pressures on them. You know, there are so many different moving pieces when it comes to sex drive for those people. But if you can identify testosterone as one of them and you can fix that, why not? But it comes with more homework. So the British Menopause Society are more fussy. Like we would never do a blood test for menopause. You cannot diagnose menopause in an older woman, 45 plus, with a blood test. You purely diagnose it by listening to their story and saying, yeah, that smells like menopause. But we would always do a baseline total testosterone blood test for someone who's contemplating embarking on a testosterone therapy. We're then told we need to monitor the blood levels initially after 6 to 8 weeks and then regularly thereafter, which we do yearly here as a rule. We don't do that with HRT. We use enough estrogen to get the job done. And if the job is getting done, you don't need a blood test, you know?
Yeah.
A lot of private clinics do love doing blood tests. Yeah.
Yeah, and that's the thing. And I think it's really important to get that message out there that menopause is not diagnosed on a blood test, certainly in older women, like you say.
Absolutely
whatever by under
not.
40, when they're experiencing those symptoms, yes.
No.
But a blood test will not diagnose menopause because your FSH levels and all your other levels are up and down anyway.
It is constantly changing.
Yeah.
I mean, depending on the day you take the blood, the time of the day you take the blood, you can get tenfold changes in levels. And what is that contributing to the diagnosis? Nothing. Moreover, if somebody's already on HRT and their symptoms aren't fully controlled, doing a blood test at that point is probably completely unhelpful. Because again, you can get a tenfold change in the results depending on what day and what time you did the blood test. So there is no science to support using serology, using blood levels to decide estrogen dosing. And yet you see that in some private clinics quite regularly, you know. Mm-hmm. And maybe eventually there will be. And maybe we'll have a lab whose estrogen assay technique is so fancy that we can get a good sense of available systemic estrogen. But we don't have that at the moment, no. With testosterone, we do, though.
And just to say as well, those OTC or those tests that you can buy online for menopause are an absolute waste of money.
I would imagine there are things like they're probably FSH. Mm-hmm. So follicle stimulating hormone is a hypothalamic, a brain hormone that tells other glands in the body, your ovaries, your pituitary, to get their act together when it comes to hormone production. And if your ovaries are getting tired and weak and not doing their job, FSH tries to kind of wake them up. So FSH, I always say, is like your mom trying to get you out of bed in the morning. It'll scream louder and louder until you get up. So if your ovaries are failing, your FSH starts screaming and the levels go up. But they can go up and then come down again. So just because you have one elevated FSH does not mean all your symptoms are menopause. That would be a useful tool for someone in early menopause. So if you had elevated FSH and you're under 40 and you don't get periods regular, you got problems. And maybe one of them little chemistry sets from the pharmacy would be a good idea to do. Because like if you got a high FSH, this is only for younger women now. Go talk to your GP and say, maybe I should get some real FSH testing done here because I don't bleed every month. And I think I might be going through early menopause, Yeah, definitely. But for the typical, I'm 45, I bleed from time to time, I got flushes, sweats, mood changes, dry vagina. Do you need a pharmacy test? No, you do not. Do not waste your money. Yeah, it is a waste of money. There's no science there.
Okay. HRT as a preventative for, say, dementia and osteoporosis, if you don't have any other symptoms.
Yeah. Osteoporosis, no-brainer. So estrogen is a main driver of what they call coupling. The bone is a living organ. It's constantly being changed. It's remodeling itself all the time. Every time you jump down off a step and you crack a piece of bone, it fixes itself. Every time the dog bumps into you and you crack a piece of bone, it fixes itself. And it does it through a process called coupling. Little osteoblasts come in and they suck out the damaged bone. And then a couple of weeks later, osteoclasts suck out the damaged bone. Osteoblasts create new, fresh, healthy bone. That only works when estrogen levels are maintained. And if you lose estrogen in menopause, you inevitably lose bone. How quickly you lose it and whether or not it's going to have consequences depends on your genes and your lifestyle. So using long-term HRT can actually be a first-line preventative therapy for osteoporosis and fragility fractures. Absolutely. And I don't think it's utilized enough for that purpose. But if fractures are waiting for you, if you have a calamitous genetic predisposition, if you're very slim, if you're, if you drink too much, if you smoke, you're likely going to break something anyway. But at least a little bit of estrogen could help balance that out a bit. And a lot of people will stay on their HRT longer than they need it for symptom relief because they enjoy the bone protection they derive from it. You do eventually lose that bone protection when you come off of HRT. So if you are high risk for fracture, you should probably look at some other therapy and talk to your GP or maybe get a referral to a rheumatologist if you're very high risk to look at other strategies. But while you're on HRT, your risk of fracture is reduced. There's no question about it. It's different with dementia because dementia it's a blanket diagnosis of 1,000 different types. So there's loads of different dementias. One of them is vascular dementia. Theoretically, long-term use of HRT might prevent vascular dementia because vascular dementia comes when the blood supply to your brain is compromised by clogging of the arteries that supply blood to the brain from the heart. So people who get strokes can sometimes mini strokes can end up with dementia depending on which part of the brain the stroke has happened in. Using HRT long-term might, in fact, prevent the incidence of that. But when it comes to things like Alzheimer's, presenile dementia and senile dementias, which is just wear and tear and aging in the brain, which we really haven't got a good idea of why that happens and how to prevent it. I'm not sure that there's any data. Pauline Mackey, Professor Mackey out of the University of Chicago, is very clear on this. She's a dementia specialist who loves her HRT and menopause cohort, and she's done a lot of work. And she said, listen, if we could prevent Alzheimer's with HRT, the whole world would be on it, men included. And we can't say that. So no.
But it is primarily a disease of females more than men, and that's why they think that's why there's this kind of ambiguous linking of it.
I'm not sure that they've completely confirmed that isn't partly because we live longer. So yeah, more women might be diagnosed with dementia because there's more women over 70 than there is men. Yeah, I'm not sure.
Yeah, no, it is a tricky one as well. It is tricky, isn't it?
But thankfully there is a little bit of push there and there is some work being done, whereas heretofore, nobody really cared about women's health. Like a lot of the medicines we use, even the SSRIs that we use as an alternative to women with breast cancer, all the SSRI trials were done in men. They were never done in women.
Oh, I know.
And never done in women of reproductive age because they were afraid someone would accidentally get pregnant during a drug trial and we'd end up with birth defects linked to their drug. So all these drugs, so many of the drugs that we typically use for females were never actually trialed in females. And it was only after they were released onto the market that we got some post-release impact studies, which is why I think some of our ladies respond so well to tiny, tiny subtherapeutic doses of some of the stuff we use, because the stuff we use, the doses were decided among men and not ladies,
We could do a whole podcast on clinical trials. Oh my goodness, don't get me started on the, the lack thereof when it comes to the women. Body odor and smell can change during perimenopause and menopause, and some women find that somewhat of an issue. Have you experienced people talking about that, or?
I can't say that I have.
Really? Okay.
I'm fascinated to hear that.
Yeah, they just I think there's, because of the change in the bacteria in the vagina and that, some people find that they may have a different smell down there, or it might be a little bit more smelly or not as pleasant a smell as they were used to it.
Well, that could be because of lack of acidity. So the vagina is designed to be an acidic environment. You want your pH under 4.5. If the pH goes above 4.5, you can start to get problems. And one of the first signs of problems is an odor. That's not a disease. It's just a pH regulation issue. So, and I think sometimes people who wash too much.
Yeah.
And there's a lot of people out there, vagina is self-maintaining for the most part.
You do not need any kind of a douching or any kind of those intimate washes. Yeah. But nothing in there except Vagifem.
But nothing. Yeah, exactly. I was just saying, there's a few things you can put in there, but one of the things I would not put in there is soap and water. Okay. Definitely not soap and water. She'll do her own job. I mean, obviously you got to wash your vulva because you got urine, you got feces, you got to get that off. But you don't want to go too deep with your detergents and cleansing products into the cavity of the vagina. She don't need it. So I could see where there might be an odor adjustment there. Because with the atrophy and the lack of estrogenization of the vaginal tissues, you might lose some acidity, and then you might get an odor as a consequence. An overgrowth maybe of Gardnerella or one of the other flora that can increase odor. I don't know. You know what it is? I think I'm living in a kind of a bubble of great need, meaning the patients I've seen for the last 3 years are people with significant, serious medical diseases. And when I ask for their top 3 symptoms, body odor doesn't generally come into there. No.
It's literally so far down the list.
But if I kept going, I don't even have it on my green. I don't think it's on the green climacteric score. The 20 top.
It's probably something that women anecdotally throw out there, and it isn't necessarily something that's, obviously when it comes to, as you say, symptoms, it's probably not something that's way up there in terms of something that really bothers them.
I have heard and read in books and stuff and seen in films that there are midwives who can smell when somebody's pregnant.
I'm not surprised.
From their body odor.
Yeah. Well, my mother's a midwife and she always said she could smell it. She could tell if someone was pregnant literally immediately after conception. So.
Yeah, and that makes sense. And so if there is a body odor adjustment with extra sex hormone, as you have in early pregnancy, wouldn't there likely possibly be a perceptive body odor change in estrogen deprivation and fluctuation? Yeah, there could easily be. I suppose it depends on how significant of an impact it has on your quality of life, whether you want to do anything about it. But it certainly wouldn't be in the top 20 of this is ruining my life presentations that I've dealt with. Yeah. But I never say never. I mean, there could be I've seen 150 symptoms attributed to perimenopause and menopause, so.
There's so many of them.
Yeah. That formication one, feeling of ants crawling across
burning tongue. Itchy ears, so much of it. There's loads.
Restless legs is a huge
one. I know.
We see a lot of restless legs in people who've had breast cancer therapies as well. And it sounds like a goofy symptom, but it's actually quite a significant disruptor, especially if it happens when you're trying to get a good night's sleep.
And what do you recommend for that?
There's very little helps. I mean, we usually dance around the other symptoms first. I have seen a little bit of support for low doses of supplemental drugs or supplemental elements like magnesium and stuff. Yeah. But then I read of cases where people overdosed on magnesium, gave themselves all sorts of side effects. So everything with a pinch of salt,
And then in terms of calcium supplementation, people don't realise that we live in Ireland, we've loads of milk, cheese, green leafy vegetables. We can get a lot of our calcium actually from our diet.
If you have a good diet rich in calcium sources, you don't need calcium supplementation. And really the only person who absolutely needs calcium supplements are people who are on calcium using drugs. So bone density drugs like the bisphosphonates and Prolia suck calcium out of your blood and pump it into your bones. So if you don't supplement your blood calcium calcium, you're going to be deficient and you could get heart problems. You absolutely have to take calcium supplementation. But for the normal middle-aged menopausal lady who wants good, healthy bones, eat well. That's the key. The only thing I will say probably does deserve supplementation is vitamin D in the winter.
Yeah, of course.
Yeah. And especially if you're not a dairy person, if you don't do cold milk and cheese and eggs and things like that have good vitamin D. I don't think of eggs, but certainly what else has got vitamin D in it? Green leafy vegetables, I think, have vitamin D. I mean, the sun is key, but then we can't have the sun because we'll end up with a little melanoma, and you don't want that either. So, they're trying to kind of compromise, saying, okay, go without factor 50 for 10 minutes, and then
apply it.
as if I'm going to bring the factor 50 with me, I usually put it on with my moisturizer. So, I think vitamin D in the winter is, and it's a safe enough drug in that, as long as you're taking recommended doses, you're not going to end up with vitamin D toxicity.
Yeah, exactly. You did mention PMDD. I know we're not strictly talking about menopause, but PMDD is something that is poorly understood, and there's a lot of women that feel that they...
Yeah, there's a crossover. I think there is. If people who are vulnerable to hormone-related symptoms, and that could be people with postnatal depression, people with PMS, PMDD, I often will find them in the menopause clinic. So it's a lifetime's sort of trajectory of my hormones can play games with my well-being. So, and we certainly find that with women with relatively early perimenopause, like women between, say, 40 and 45, there's a huge overlap between what we would recognize as PMS, PMDD symptoms and their perimenopause. So irritability more than depression. Cyclically measurable irritability. So that premenstrual kind of rage, irrational anger kind of thing that some people, not all, get in PMDD and PMS. Physical symptoms like bloating and fluid retention, which is very common with PMS and PMDD, that can happen sporadically. People in their early 40s, middle 40s would say, oh my God, where did this come from? But it actually can be a presentation of menopause. Yeah. So there's a lot of overlap. Basically, there is a gene for PMS, PMDD, thank God. There are doctors who generally don't believe it's a thing.
Yeah, I know
and
that.
poo-poo it, It has actually now been shown to have genetic markers. We think it's a sensitivity in some of the hormone receptors in the body. So it's not that you have too much or abnormal levels of sex hormone. It's that your sensitivity to your own sex hormone is problematic for you, and that by adjusting fluctuations in sex hormone, we might give you some symptom relief. That's
and how do we adjust the fluctuations? Is it put them on the contraceptive pill, put them on HRT, or
usually we try to shut down the quite unpredictable fluctuations that ovary hormones can cause. So your ovaries always changing up the amounts and the types and the levels of the sex hormones. If you can shut down ovarian hormone fluctuation and just supplement low levels of estrogen, progesterone in a consistent sort of flat way, it can give relief. So anovulant products, anything that stops the ovary from functioning, with then add back hormone supplementation can help. And one of the commonest ones is the contraceptive pill or patch or ring. They're very, very helpful for people who can tolerate them or people who are allowed to use them. But there are people my mom had a blood clot when she went on the pill. Those girls may be better off avoiding contraceptive pills, patches, and rings that have estrogen in. And so sometimes we'll use HRT in those cases. So we'll put somebody on a strong dose of transdermal estrogen, which we know is not going to be a blood clot risk factor or much less of a one. Obviously, if they have a womb, we do have to give them supplemental progestogens so as to protect their womb lining. But generally, we try to use one of the progestogens that have the least androgenic properties. So something like dihydrogesterone or micronized progesterone. So I don't do PMS, PMDD that much anymore because I'm not in the general women's health game anymore. But there's lovely resources available online. The Professor Nick Panay in the UK, he is involved in the pms.co.org.uk, is the premenstrual syndrome society over there, and they're actually starting to really up uptick their website, and they're getting loads of resources for both doctors, nurses, and patients.
Okay, and then Deirdre, just to finish off the menopause talk, where can people go? Because there's a huge amount of information out there, and some of it's BS and some of it's great, and it's very hard to cut through all that noise.
Yeah.
Where can a woman go today to find the resources that she needs? Is there a one website?
Yeah. There's no one best one. At the moment, I think some of the more comprehensive ones would be like the British Menopause Society's own website. Some of it is inaccessible unless you're a member. Some of it is available to everybody. But they have a patient-facing arm called the Women's Health Concern, WHC. And if you go to the British Menopause Society homepage, there's a link to that there. And everything that's on there is safe and supportable. That's the best I can say about it. So I use their resources quite a bit. There are other people that, depending on what's going on with them, I recommend, like Dr. Hannah Short in the UK has a personal history of premature ovarian insufficiency, and she does a lovely website that gives great resources for people under 40 who've been diagnosed as fully menopausal, POI, we call that. So her site is really good for that stuff. There isn't a great site for people after breast cancer. I wish there was. But the very good news is only just this month we have come together, some of the menopause experts in Ireland, in the Republic of Ireland, and other interested medical individuals, and we have decided to breathe newer life back into the Menopause Society of Ireland. So we're going to have our own 26 counties group, mostly made up of doctors and nurses, but we're also going to request participation from pharmacists, physiotherapists, psychologists, to really get a locally homegrown one-stop shop resource for both patients and prescribers and anybody in the healthcare profession that deals with people who are affected by menopause, to be able to go to one site to get all the up-to-date information they need. Yeah. So there's about 12 of us on the directors. We've developed a board of directors, and one of the little sidelines that I volunteered to be very involved in is the website. So I don't know how long it's going to take. It'll probably be the guts of a year before we're really in a good place with it. But certainly hopefully by the end of this year, you'll see the first version of the Menopause Society of Ireland. And we'll have a big section there that'll be resources for patients.
That's brilliant.
I'm excited.
And then there's your book that people can also...
Well, a book is out of date the minute it's written. So the book is good. I think the book is good. I try to make it practical and easy to read. But when you want, what about that study? Like there's just a study the other day about arthritis and stuff. If you want a place that gives, contemporaneous information about menopause, hormones, choices, you got to get a website.
Okay. Deirdre, I could talk to you all day, but we need to wrap it up because you need to go.
I've enjoyed it. I could sit here all day.
Great, isn't it?
Yeah.
I wanted to ask you, Ma, what advice would you give young people today?
I thought about this because you were very kind to give me some forewarning. I feel, I don't know if it's true or not, that I spent the first 3/4 of my life doing stuff because I thought I had to do it. Okay, I have to do this, I have to do that. I don't know, for different reasons. You don't have to do anything. I mean, within reason, you got to feed yourself. You got to make a place for yourself in society. But as best you can, try to think about what gives you joy and pursue that. And stop telling yourself what you have to do.
That's fair. And what is the meaning of life?
I have zero. Like I'm a cynic. I think anyone who thinks they know what the meaning of life is, I'm suspicious of that. I don't buy that. And again, I think it goes back to finding some joy. Life can be really hard, and it's much, much harder for others than it is for some. You know what I mean? I've been relatively fortunate, I feel, compared to some of the people I meet in the clinic, and I don't know why my luck has been so good up to now, and other people's is so complete crap, and it's just luck of the draw as far as I can see. It's nothing you did. It's nothing you chose. It's just... But I think that if you have the blessing of family and friends, you should take the support that's out there, because I think that may be part of what this is all about, is keeping close to people who mean something to you.
Dr. Deirdre Lundy, it is an absolute pleasure to deal with you.
Thank you for having me.
And it's been, we'll come back in a couple of years' time when there've been more studies, yeah? And we can discuss them.
I would love it.
Thank you.